So hello friends. So I'll be talking on this important topic, albumin in chronic liver disease. So it's an important topic to have a reasonable clarity on established indications for the use of albumin. And there are certain conditions where its use is not fully established, but possibly it could be customized by a clinician with tangible benefits. And we look at the controversies where possibly this should not be used. So this is a good topic for intensivists to ponder about and have a clarity or on where albumin could be used as a definitive sort of a utility. So the first three slides, I'll talk about the whole pathophysiological aspects as to why albumin holds some promise in CLD. So when you look at the whole ascites formation in a cirrhosis or CLD, the main pathognomonic feature that happens is at the vascular level. So this is just a schematic representation. So this is a vascular lumen. This is the endothelial glycocalyx layer, and this is the interstitial space. So what really happens in chronic liver disease is the capillary hydrostatic pressure increases in the vascular lumen, and there is concomitant reduction in the oncotic pressure. So because this oncotic pressure is very much dependent on the intravascular albumin. So when there is a reduction in this oncotic pressure, so there is a extravasation of fluid from the vascular compartment into the interstitial space. And there is increase in the interstitial pressure, which continues to draw the fluid from the intravascular compartment to the interstitial space. And the diuretics that are commonly used to treat ascites or this situation typically acts by reducing this capillary hydrostatic pressure. And interestingly, what is also shown as a pathognomonic feature is there is increase in the JV. So JV is the transendothelial fluid volume that extravasates is termed as JV. And the reason we give diuretics is to reduce the GV so that this extravasation of the fluid does not increase. So the transendothelial extravasation of the fluid volume is termed as JV. And along with this, in cirrhosis, there is a lymphatic drainage also that tends to happen from the vascular compartment, which leads to the ascites formation. So along with this, what we need to understand is there is increase in the venous pressure. So the back pressure, or as you would have heard, the portal venous pressure increases in CLD. And because there is increase in the venous pressure and there is venous congestion, there is a reduction in the organ perfusion pressure also that typically sets in the chronic liver disease. So all this together forms a vicious conundrum which causes all the sort of complications that one would witness in chronic liver disease. So when you look at chronic liver disease in cirrhosis, so there is a smoldering inflammation that is happening within the liver. Along with this, there is a lot of fibrotic changes that happens at the cellular level, and the cellular synthetic function comes down. And along with this, there is a lot of angiogenesis that is happening in the liver, and there is microvasodilatation also within the liver that tends to happen. Because of these fibrotic changes within the liver, there is reduced production of albumin because there is loss of cell volume in the liver and there is reduced production of albumin. Along with this, there is the chronic liver disease or cirrhosis is a low flow state. So there is a slow sort of a venous flow which increases the portal venous pressure. So that I'm sure most intensivists would have heard, there's increase in the portal venous pressure. Because of its increase in the portal venous pressure, there is increase in the JV. JV, as I said, is the transendothelial sort of transit of the fluid that happens. So the transendothelial volume of fluid that gets extravasated is JV. So there's increase in the JV, which draws fluid from the vascular compartment into the interstitial space and the other spaces. And because there is reduced albumin production because of a lot of fibrosis that happens with loss of cell volume, there is a reduction in the oncotic pressure. And this reduction in the oncotic pressure also contributes to increase in the JV, which is transendothelial movement of fluid. The transendothelial volume of fluid that moves is JV, and that increases. So all this together leads to all this ascites formation and all the other complications that ensue. So the treatment in cirrhosis, as you would know, is directed to increasing in the oncotic pressure, because as we see, the oncotic pressure is the one which is increasing the JV, and oncotic pressure reduction is what pushes the fluid from the vascular compartment into the interstitial space. So the treatment is guided at increasing the oncotic pressure, reduction of portal venous pressure, and obviously the treatment is directed in removing a lot of ascites to reduce the pressure. and diuretics and beta blockers also are sort of used. So as you see here, the whole emphasis would be on how we tackle this reduction in the oncotic pressure. And to reduce portal vein pressure, you possibly would use beta blockers and diuretics. These are medical therapies. But one of the other important component which could be utilized to increase the oncotic pressure to keep the volume within the blood is the albumin. So that's what we are here to deliberate. What is the established rule? So when we look at established uses of albumin, there are three sort of a main categories where albumin use is established and one could use it with a fair justification. One is large volume paracentesis. So large volume paracentesis is where we are draining the ascites fluid more than 5 liters, even up to 5 liters, even 4 to 5 liters of drainage of ascites constitutes a large volume paracentesis. And what it leads to, because you're removing so much of fluid, there is shifts of fluid from the intravascular to extravascular, which can lead to reduction in the effective blood volume. And this leads to paracentesis induced circulatory dysfunction. PICD is the paracentesis induced circulatory dysfunction, and it tends to occur in 70% of the acute and chronic liver failure, even with 3 to 4 liters of moderate volume paracentesis. Also, this decompensation, which we call as paracentesis induced circulatory dysfunction, tends to set in. So replacement of albumin, so the replenishment of albumin at a dose of 8 grams per liter. So for every liter of ascites that we drain, replacing it with 8 grams of albumin has shown to reduce the occurrence of shock and reduces the occurrence of hyponatremia, reduces the occurrence of acute kidney injury hepatorenal syndrome, and even it is shown to reduce the encephalopathy and mortality. So there are studies to substantiate this. One of the studies, Aurora et al., where they have shown the utilization or replenishment of albumin at this dose reduces the occurrence of paracentesis induced circulatory dysfunction by 30%, and it does reduce the risk of complications and mortality. So this is one sort of an indication where albumin could be used in a justifiable way. And the use of albumin also helps in preventing the increase in the plasma renin, and it does increase the oncotic pressure, which tends to prevent this post paracentesis induced circulatory dysfunction. And it is also shown to improve the renal perfusion. So that is the first sort of a established cause. The second established cause is acute kidney injury hepatorenal syndrome. So as we know, because liver cirrhosis itself carries a lot of morbidity, because liver is an important organ which tends to purify the blood with a lot of toxins. So alongst with it, if there is an acute kidney injury, it does carry much poorer prognosis. So we are aware of that. And recurrent AKI is something that tends to happen in chronic liver disease, which can lead to chronic kidney disease. So in this, the usage of albumin at 1 gram per kg, maximum of 100 grams per day on day 1, followed by 20 to 40 grams per day, has shown to reduce occurrence of AKI. So there was this study. So there are good number of studies that has come from India, quality studies in this sort of a area. So this study looked at comparing albumin with terlipressin versus albumin with noradrenaline. And this study, they showed albumin with terlipressin was found to be superior to albumin with noradrenaline in preventing or mitigating or minimizing acute kidney injury hepatorenal. And I'm sure many of the intensivists would be using this sort of a regime when someone comes to ICU with AKI. So the first established cause is large volume paracentesis. Second established cause is AKI and hepatorenal syndrome. The third established usage of albumin is spontaneous bacterial peritonitis. So it is shown that the 30% of the patients of CLD tend to develop spontaneous bacterial peritonitis, and SPP tends to have recurrence in CLD, and it does increase the risk of AKI. When SPP sets in CLD, there is a risk of AKI also that sets in, and there is increase in the mortality. And the use of albumin, as we saw in AKI, definitely helps in reducing the risk of AKI. It does improve the preload, and then it does increase the peripheral vascular resistance. And by doing so, it does improve or leads to favorable benefits. So in SPP, how does albumin help? So albumin basically is a protein that is needed. And we know hypoalbuminemia is something that prevails in CLD. So albumin is required to bind with all the toxins in the blood. So albumin binds to nitric oxide, It does bind to tumor necrosis factor alpha and interleukin 6. All these inflammatory markers it binds. So you need albumin to bind to these toxins so that the deleterious effects of these cytokines could be mitigated or avoided. So that is where you need albumin. So low albumin leads to free circulation of these toxins, leading to vasodilation, hypotension, and the vicious conundrum. And albumin is also shown to stabilize the vascular endothelium, and it does reduce the intravascular factor 8 and does reduce the von Willebrand related antigens. So these are some of the effects in which it tends to act and minimize the morbidity and mortality associated with SBP. And so there are two studies that have shown the benefit of using albumin. So this was one study which came in 2009 where they used albumin 1.5 grams per kg within 6 hours, followed by 1 gram per kg at day 3. So this is the dose they used in patients with SBP. So within 6 hours, they use 1.5 grams. So as you see, the doses are fairly variable in multiple studies for different conditions, and this is not something that is standardized. And I'm sure most listeners would know we wouldn't be using this dose. So 1.5 grams per kg would amount to 100 grams of albumin. That would be quite prohibitive with cost in our country. But these are the doses that have been used in this study, and this has shown to reduce the type 1 hepatorenal syndrome by 60%, and it has shown to reduce hospital mortality and the morbidity as well. So this was one study, and the criteria they used for administering albumin was bilirubin more than 4 milligram per deciliter, creatinine more than 1 milligram, and blood urea more than 60 milligram per deciliter was used as a criteria in this study to use albumin. And so now the question is, should we use this dose? So there was a study that came from Brazil where they showed in patients with SBP, even low dose human albumin solutions prevent AKI HRS. So possibly in our country, we wouldn't be using 1 gram, because 1 gram means if it's 60 kgs, you would have to use 60 grams of albumin. So which is 3 bottles, because one bottle contains 20 grams. So we wouldn't possibly use that high dose because of various reasons. So we could substantiate that even low dose human albumin solutions could be at least considered to prevent AKI HRS in patients with SBP. So the 3 established causes which I mentioned were large volume paracentesis, AKI HRS, and SBP. So these are the 3. So this is one area which was very exciting until last year, where this concept was debunked. So there are good studies where they have tried to use albumin as a long term, up to 1 year, 1.5 years, to prevent sort of a decompensation and morbidity and mortality. So long-term albumin therapy. So there are good studies. So Wilkinson and Sherlock, way back 60 years back, showed repeated albumin infusions to maintain good oncotic pressure helps in improving the outcomes. But unfortunately, no survival benefit was found. Then there's few landmark trials that came. So to look at whether there is any mortality benefit. So one of the landmark trial was the ANSWER study. So this came from Italy, where they used albumin along with the standard therapy and compared to the group which got standard therapy for up to 18 months. So they treated patients with albumin for 1.5 years at a dose of maybe 40 to 60 grams per day, 40 to 60 grams every week they tended to use. And here they showed that albumin and with standard showed much lesser mortality as compared to only standard therapy. After this, there was another Italian study by D. Pascoli. Even here, they showed that mortality was significantly less when albumin was used along with standard. In this D. Pascoli study, they used 40 grams per week for 1.5 years, and that amounted to $34,000, which is very, very cost prohibitive. So possibly that is the reason these regimes is maybe difficult to adopt in a country like ours, where cost can be a limiting factor. But this is the sort of regimes they used in this study. And number needed to treat to save 1 life was 9 in this particular study. So in the ANSWER study, where again they used albumin alongside standard for 18 months on a weekly basis. So albumin plus standard therapy reduced the recurrent ascites, reduced the occurrence of AKI HRS, reduce the occurrence of encephalopathy and bacterial infections, and reduce the hospitalization. So these were the 2 positive studies, ANSWER study and the D. Pascoli study. Then there was one Spanish trial also where they looked at midodrine and albumin. It's called a matched study they used albumin every 2 weeks and they did not show any benefit. So then this study came most recently in 2020, which debunked this whole thought process that long-term utilization of albumin will make any difference. So this was a big UK study, UK attire study done in 35 centers, 808 patients. Here they used albumin once a day for 2 weeks to keep the target of albumin more than 3.5 grams per deciliter. Unfortunately, this study did not show any benefit in reducing the complication or 3 month survival, or no, there was no benefit in with regards to adverse events also. So basically, this study debunked the whole thought process that long-term utilization of albumin has any sort of a benefit. So possibly at this point of time, we could hold on to giving this long-term albumin every week, possibly taking cue from this study. So that is about one area. So now we will slowly move into possible uses of albumin, where there is no sort of a absolute justification in using, but this could be customized to certain patients. So hypervolemic hyponatremia. So I'm sure every listener would know CLDs would have hypervolemic hyponatremia, and it is shown that hyponatremia less than 130 is associated with bad prognosis. And the typical therapy that we would institute is fluid restriction. We may use Vaptans or hypertonic saline. All these have found to have limited efficacy in definitely correcting the sodium. So here they've used 40 grams of albumin is shown to increase the sodium by 9 millimoles per liter by using this. And this tended to have long-term reversal of hyponatremia. And this is something one could customize for someone who has chronic hyponatremia, which is not amenable to fluid restriction, Vaptans, and hypertonic saline or soda mint. All these therapies, if still patient remains hyponatremic, which may be associated with bad outcome, one could possibly think of it in concurrence with the hepatologist. And this is an interesting area for intensivists. So often we see patients with CLD coming with sepsis other than bacterial peritonitis. So very often they may come with bacteremia with septic shock. They may come with UTI with septic shock, or they may come with a pneumonia with septic shock. So here they have done good studies. I thought these studies were important for intensivists, where they showed good benefit with use of albumin. So this was a study which came from the French group, Thivenot et al., where they, in patients with sepsis, which is not due to SBP, they used antibiotics along with albumin and compared with antibiotic alone, 96 patients in this group and 97. And the dose they used is again 1.5 grams per kg per day on day 1, followed by 1 gram per kg per day on day 3. And they showed delayed onset of AKI in the group which was given albumin along with antibiotics. So there was this another Spanish trial which came, which also showed giving antibiotics with albumin improved survival. This is the most recent study which came in 2020, INCIFER study, where they used antibiotic with albumin versus antibiotic. This was a European multicentric study. Again, here it showed, or they used 1 week albumin and they showed improved recovery with this. So this may be of some relevance to intensivists, where we do see CLDs coming crashing with septic shock, not due to SBP or even SBP or no SBP. Adding albumin seems to show signals towards having some favorable outcome benefits. So this could be kept in mind for an intensivist is what I would say. The way, again, it is hypothesized is albumin binds to this toxin prostaglandin E2, and this tends to enhance the phagocytic function within the body, which tends to lead to sort of favorable outcome benefits. So then albumin in critically ill cirrhotic, there was a very good study that again has come from India, which is called FRISK study. FRISK study is fluid resuscitation in septic critically ill patients. So this was an Indian study of 304 patients. Here, see, they have used 5% human albumin. So I remember when I was in Australia, we had 4% albumin available, and we used to use that as fluid resuscitation. Here they've used 5%, and I hear 5% albumin is available in our country as well. Here they use 5% human albumin and compared to 0.9% saline as a resuscitation fluid. And they found reversal of hypotension was much better when 5% human albumin was used, 11.7% recovery versus 3.2% recovery in saline. And that was significant as well. And they looked at a lot of secondary endpoints, and they showed in the albumin group, there was improvement in the heart rate, improvement in the lactate clearance, tissue perfusion, and early survival was found. So it's a FRISK study, something you can cite when maybe in CLD who comes in a septic shock to ICU, if resuscitation is needed, rather than using saline, if we have 5% albumin, is something that one could keep in mind. So how about hepatic encephalopathy? So this is a very sort of a common presentation in ICU and a very troubling sort of a presentation. So why does hepatic encephalopathy happen? So this is the blood-brain barrier, as you see. So when there is hypoalbuminemia, there is increase in the tryptophan within the bloodstream, and because in CLD, this tryptophan crosses the blood-brain barrier and leads to a lot of neuroinflammation, and that leads to sort of a chemical locha and the hepatic encephalopathy that tends to set in. And albumin is shown to prevent catabolism of muscles and prevent the metabolic disturbance. So there are 4 studies in hepatic encephalopathy. So again, the answer study showed that use of albumin does reduce the risk of hepatic encephalopathy. And this was another study from Italy. 3 weeks they gave albumin and did not show benefit. So there are totally 4 studies. The other 2 studies which came from China and Spain, where they showed with the use of albumin, there was improved survival, but there was no sort of a evident reduction in hepatic encephalopathy, but they did show improvement in survival in patients with hepatic. So all in all, if you look at 4 studies, there were 3 studies in hepatic encephalopathy, which tends to favor that albumin appears to have some beneficial effect. So this is something, again, you could customize to some patients who are troubled with recurrent hepatic encephalopathy in concurrence with hepatologist. So how about hemostatic effects? So albumin is shown to enhance the neutralization of factor 10A by the antithrombin 3. And another problem with low albumin, so hypoalbuminemia, is the platelet aggregability of the platelets tend to increase. So you need to have albumin. As I said, albumin binds to toxin like nitric oxide and prevents the aggregation of platelets. So for the platelet clumping not to happen, you need to have adequate level of albumin. Because it binds to all the toxins, which leads to aggregation of the platelets. So here there is a suggestion, or there are anecdotal reports where albumin dialysis, single pass albumin dialysis, where you give albumin so that albumin binds to all these toxins and prevent the platelet aggregation, is something that is considered. And this, again, as I said, these are possibly has to be customized to special group of patients, possibly who are posted for liver transplant or who are posted for some surgery to optimize the platelet function. And how about cirrhotic cardiomyopathy is something that tends to occur in some patients. So albumin is shown to improve the cardiac output, improve the AA gradient. And this was one study from Germany, Umgelterer, where they showed use of albumin helped in increasing the cardiac index by 10% in cirrhotic cardiomyopathy. So acute and chronic liver failure, again, there is an ongoing trial. So we know the pathophysiology. There is inflammation, fibrosis, vasodilation, and there is bilirubinization of albumin and endothelial injury. So there is limited data in this. There is an ongoing trial called Asia trial. So the reports of which are awaited to see whether albumin has any favorable benefit in this group of patients. So albumin dialysis, so in liver failure or chronic liver disease, there is accumulation of a lot of toxins in the blood, and some are water soluble toxins and some are protein bound. So water soluble toxins are blood urea, creat, uric acid, ammonia, and the cytokines like interleukin 6 and TNF alpha. And there are toxins which are dependent on albumin to be bound. Because albumin is deficient, these toxins circulate in the blood, which I said. So these are bilirubin and bile acids which need albumin. They bind to albumin, and then mercaptans bind to albumin. Aromatic amino acids bind to albumin, and phenols. So these are the toxins which should not be circulating freely in the blood. They should be bound to the albumin. And these, in the situation where there is deficient albumin, these toxins tend to circulate. And so this was one trial, again, which has come from India, where the use of albumin is sort of suggested in patients with MELD score more than 30 or acute and chronic liver failure research committee score of more than 11 tends to improve outcomes by binding to these toxins and preventing free circulation of these toxins. I'm sure many listeners would be aware there are now filters available which are specifically designed to absorb all these liver toxins like mercaptans, aromatic amino acids, and they're used as an extracorporeal circulation. But we need larger studies to see whether this usage of these filters really change the outcome, by their by understanding that it binds with all these toxins in the blood. So these filters are now currently available. So we need larger data to see whether use of these filters in reducing these toxins in the blood tends to improve the outcome. And we spoke about SPAD. So what about the controversies about albumin use? Isolated hypoalbuminemia. So just treating the number, low albumin per se is not an indication, and it is suggested that 40 to 90% of the time where albumin is used in CLD to correct the number is unjustifiable. So that is something which should be shunned. Just treating low albumin in CLD is not the way. And we spoke about all the established causes and the possible situations where one could use. And post liver transplant is a controversial area. So more than 3 grams per deciliter maintenance of albumin has shown to improve organ function, preserve the cardiovascular function. But what has been shown in liver transplant is giving albumin infusion reduces the effect of tacrolimus, and which can increase the risk of graft rejection. So this is another diabolical side of using albumin in liver transplant, which one needs to keep in mind. So just last slide. So we'll talk about what are the research frontiers and newer albumin molecules. So we need a synthetic sort of an albumin which is stable, easy to store, and with a longer half-life, because the half-life of albumin ranges from somewhere between 16 to 18 days or 20 days, after which the albumin disappears from the system. So we need a molecule which can remain longer in the blood. So to that effect, there are sort of research happening in developing superalbumin molecule, because the half-life of the albumin is dependent on the C terminal. This is the C terminal. This is the chemical structure of the albumin. So the maintenance of the C terminal is shown to increase the half-life of the albumin, which they call as superalbumin. And even there are transnasal albumin which is being developed, which has a better sort of a transcellular action. And there is an addition of this molecule 1,6-bis alimedohexane. By adding this, it is shown to have a better antioxidant effect from the albumin. So together with this, they call this as a superalbumin. I'm sure there is a science evolving in this area to develop albumin with a lot more stability, longer half-life, and more antioxidant effects. So another important thing is we need more trials in patients, because we do see patients with CLD and CKD coming. So we don't have trials of whether albumin helps in this segment. And we have spoken so much about AKI and hepatorenal. We do not know about the role of albumin in hepatopulmonary syndrome. And we see a lot of patients coming with diastolic dysfunction. I'm sure many of the listeners would know, rather than systolic heart failure, we see more of diastolic heart failure. Whether albumin has a role in this needs to be evaluated. Role of albumin in TIPS needs to be evaluated. And since there is a lot of muscle wasting that sets in, and the catabolism that's happening, and the sarcopenia that is prevailing, substitution of albumin, whether it alters the sort of a muscle mass condition, is something that needs to be seen. So these are some of the areas where we need more trials, more data to substantiate uses of albumin. And the questions still remain on the dose, because you saw so many trials. So we saw some trials using 1.5 grams per kg, some trials using 1 gram per kg, some trials using 40 grams, and even low dose human albumin. And every condition they've used different doses. So we do not have standardization of the dose that needs to be used. And even we do not have standardization of the duration. How long can this albumin be used? Because you saw there was one trial where they used every week. Then most studies used on day 1. In SBP, they used day 1, 1.5. On day 3, they used 1 gram. So there is sort of a varied usage. So there's no standardization on the duration of albumin and frequency, how frequently. So these are questions which are still unanswered, and there is no homogeneity in the thought process of this. So the take-home message, the established uses of albumin. So for all the listeners, if you can remember this slide, it should be good enough. Established is large volume paracentesis, AKI, HRS, and SBP. These are the established. Long-term usage of albumin, there were good trials. The ANSWER trial, Deep Escoli trial were there, but then the UK attire study sort of debunked. So right now, we are not fully convinced whether long-term albumin would help. Possible uses of albumin, hypovolemic hyponatremia in special group of patients where hyponatremia is a niggling problem. This area is very interesting for intensivists. Non-SBP sepsis. We saw that INCIFER study where it showed, and the Thivenot et al. Study, so where it showed some favorable benefit. This is something which one could keep in mind. In critically ill, we had the FRISK study where they used 4% albumin as a resuscitation fluid, which showed favorable benefit. So we need more data in that direction. Encephalopathy, we had 4 studies where 3 studies showed some benefit. ANSWER study showed some benefit. So this also should be customized in patients who have chronic encephalopathy, which is not getting rectified with the standard of care. And in patients with platelet aggregation and platelet issues posted for surgery, albumin dialysis or single pass albumin could be thought of in a special group of patients in concurrence with hepatologists and septic cardiomyopathy, CLD, cirrhotic cardiomyopathy. And potential uses of albumin, we spoke about SPAD, which is a single pass albumin dialysis. Controversies about albumin, so no justification for using albumin just to correct the numbers. Post liver transplant, we saw it's a diabolical because raising the albumin does reduce the effectiveness of tacrolimus and increases the risk of graft rejection. So we possibly need to be a little moderate and judicious of replenishing this albumin in liver transplant. So this would be the summary of the sort of a clarity that we could derive from the available evidence. So thank you one and all. So I would end with this beautiful quote. So what does it mean to work on yourself? Teacher us, it is to stop waiting for others to change. So thank you one and all.